Acid-base balance is maintained by controlling the hydrogen ion concentration of extracellular fluid. Buffer systems in the body regulate the acid-base balance by taking up or adding hydrogen ions. Lungs and kidneys are the major regulators of acid-base balance. Acid-base balance is measured using arterial blood gas levels and anion gap results. Acid-base balance refers to homeostasis of hydrogen ion concentration in body fluids. Concentration of hydrogen ions in body fluids is expressed as pH. Body fluids classified as acids or bases according to hydrogen ion concentration. Acids are hydrogen ion donors. A solution containing more acid than base has more hydrogen and a lower pH. Solutions with a pH below 7 are classified as acid or acidotic. Carbonic acid is an example. Bases are hydrogen ion acceptors. Solutions containing more base than acid have less hydrogen and a higher pH. Solutions with a pH above 7 are classified as bases or alkaline. Bicarbonate is an example of a base. Acid-base balance is maintained by controlling the hydrogen ion concentration of body fluids, specifically the extracellular fluid. pH is a numerical value inversely proportional to the number of hydrogen ions in a solution. If the hydrogen ion concentration rises, the pH falls. If the hydrogen ion concentration falls, the pH rises. The normal blood pH range is 7.35 to 7.45. A pH below 6.8 or above 7.8 is incompatible with life. Acidosis is a condition in which the pH is below 7.35. Acidosis occurs when acids, hydrogen ions, accumulate in our bodies or when bases, such as bicarbonate, are lost from our bodies. Alkalosis is a condition in which pH is higher than 7.45. This occurs when bases, such as bicarbonate, accumulate or acids, such as the hydrogen ions, are lost from our bodies. The body's pH is fairly constant. The hydrogen ion concentration in the body is affected by water-diluted products of metabolism. The kidneys excrete only about 1% of the body's hydrogen ions. The lungs and other buffers in our bodies handle the remainder. Our body cells buffer by taking up or releasing extra hydrogen ions. This involves exchanging potassium, which is predominantly in intracellular fluid, with hydrogen, which mainly is in the extracellular fluid. This exchange affects the body's potassium balance. Bicarbonate buffers make up the body's primary buffer system. Bicarbonate buffers are responsible for buffering blood and intestinal fluid. Bicarbonate buffers rely on a series of chemical reactions in which pairs of weak acids and bases, such as carbonic acid and bicarbonate, combine with stronger acids, such as hydrochloric acid, and bases to weaken them. Bicarbonate buffers decrease the strength of potentially damaging acids and bases, reducing those chemical threats to pH balance. Bicarbonate buffers are assisted by the kidneys to help regulate bicarbonate production, and the lungs help regulate carbonic acid production, which itself results from combining carbon dioxide and water. Phosphate buffers, like bicarbonate buffers, depend on a series of chemical reactions to minimize pH changes. Phosphate buffers react with either acids or bases to form compounds that slightly alter pH. Phosphate buffers can provide extremely effective buffering. Phosphate buffers are especially effective in renal tubules where phosphates exist in greater concentration. Protein buffers are the most abundant buffers in the body. Protein buffers work both inside and outside of the cells. Protein buffers are made up of hemoglobin as the proteins. Protein buffers behave chemically like bicarbonate buffers. They bind with acids and bases to neutralize them. For example, in red blood cells, hemoglobin combines with hydrogen to act as a buffer. The respiratory system serves as the second line of defense against acid-base imbalance. As a buffer, the respiratory system can maintain acid-base balance twice as effectively as chemical buffers. It can handle twice the amount of acid and bases. The respiratory system responds to pH changes within minutes, but it can only restore normal pH temporarily. The kidneys are responsible for long-term pH adjustments. Blood levels of carbon dioxide, which is a gas that combines with water, forming carbonic acid, are regulated by the lungs. Decreased pH is caused by increased levels of carbonic acid. Chemoreceptors in the brain's medulla sense pH changes, varying breathing rate and depth to compensate. The body's response to low pH is to faster or deeper breaths to eliminate more carbon dioxide from the lungs. Thus, carbon dioxide level in blood drops while pH increases. The body's response to high pH is breathing slower and less deeply, thus reducing carbon dioxide excretion and lowering pH. Partial pressure of arterial blood, PaCO2, is used to assess effectiveness of ventilation. Normal PaCO2 level is 35 to 45 millimeters of mercury. PaCO2 levels reflect CO2 levels in the blood. The lungs compensate for metabolic disturbances by retaining or removing carbon dioxide, minimizing the change in serum pH. In metabolic alkalosis, bicarbonate excess, the lungs suppress the rate and depth of respirations, which causes carbon dioxide retention and carbonic acid buildup. In metabolic acidosis, bicarbonate deficit, the lungs increase the rate and depth of respirations, which causes greater elimination of CO2. The renal system has several functions and characteristics that are important in regulating acid-base balance in the body. It is the slowest of all the regulating systems and takes from a few hours to several days to adjust to changes, but it can permanently adjust blood pH. The kidneys can reabsorb acids and bases or excrete them into urine, as well as produce bicarbonate to replenish lost supplies. The kidneys regulate the body's bicarbonate level, reflecting the metabolic component of acid-base balance. Problems occur if the blood contains too much acid and not enough base. pH drops, kidneys reabsorb sodium bicarbonate. Hydrogen, along with phosphate or ammonia, is excreted by the kidneys. Urine is more acidic than normal. Bicarbonate is formed in the renal tubules by bicarbonate reabsorption and increased hydrogen excretion, eventually retained in the body. The bicarbonate level in the blood rises to a more normal level and pH increases. Problems also occur if the blood contains more base and less acid. The pH rises, kidneys excrete bicarbonate and retain more hydrogen ions. The urine becomes more alkaline. the blood bicarbonate level drops and the pH decreases. The kidneys excrete or retain hydrogen and bicarbonate to compensate. In respiratory acidosis, which is a carbonic acid excess, the kidneys excrete hydrogen and conserve bicarbonate to restore acid-base balance. In respiratory alkalosis, which is carbonic acid deficit, the kidneys retain hydrogen and excrete bicarbonate to restore balance. Arterial blood gas measurements is a major diagnostic tool for evaluating acid-base balance. ABG analysis helps determine a patient's acid-base status, evaluates pulmonary gas exchange efficiency, assesses the respiratory system, evaluates blood oxygenation, and monitors respiratory therapy. ABG levels are analyzed in blood samples by obtaining blood from one of several arteries. The radial, brachial, or femoral arteries are most commonly used. There are 6 parameters included in ABG measurements. The pH level indicates blood acidity. Normal range is 7.35 to 7.45. pH greater than 7.45 indicates alkalosis. A pH less than 7.35 indicates acidosis. Normal or borderline pH has several indications. The normal acid-base balance, or the body's attempt to compensate for slightly abnormal or chronic acid-base imbalance. PaCO2 levels indicate the partial pressure of carbon dioxide in arterial blood. PaCO2 is used to evaluate the respiratory component of acid-base balance. Normal range is 35 to 45 millimeters of mercury. PaCO2 values greater than 45 millimeters per mercury indicate hypoventilation or excessive CO2 retention, better known as hypercapnia, and therefore acidosis. PaCO2 values less than 35 millimeters of mercury manifest as hyperventilation or excessive carbon dioxide exhalation, better known as hypocapnia, and therefore alkalosis. Bicarbonate levels reflect the arterial blood's bicarbonate concentration, and they are used to evaluate the metabolic acid-base component. Normal range is 22 to 26 milliequivalents per liter. Bicarbonate values greater than 26 milliequivalents per liter indicates alkalosis. Bicarbonate values less than 22 milliequivalents per liter indicates acidosis. Base excess reflects the level of bicarbonate and other bases such as plasma proteins and hemoglobin. It is used to evaluate the metabolic acid-base component. Normal range is -2 to +2. A base excess value greater than +2 equate to a base excess or an acid deficit in metabolic alkalosis. A base excess value less than -2 indicates a base deficit or acid excess in metabolic acidosis. PaO2 levels reflect the partial pressure of oxygen in arterial blood, indicating the lungs' ability to oxygenate blood. The normal range is 80 to 100 millimeters of mercury. PaO2 levels vary with age. PaO2 levels are not used to evaluate acid-base status. It is an indicator of the blood's ability to carry oxygen. PaO2 levels less than 80 millimeters of mercury indicate hypoxemia or decreased oxygen levels in the blood. SaO2 levels reflect the oxygen carrying capacity of hemoglobin. SaO2 helps evaluate respiratory function. SaO2 levels are not used to evaluate acid-base status. The normal range is 95 to 100%. Anion gap is the arithmetical difference between the concentration of routinely measured cations, in this case sodium and potassium, and routinely measured anions, in this case chloride and bicarbonate. Cations, positively charged ions, and anions, the negatively charged ions, must be equal in the blood to maintain a proper balance of electrical charges. Sodium accounts for 90% of all circulating cations. 85% of the counterbalancing anions are chloride and bicarbonate. Although potassium is a major cation and plays a very important part in homeostasis, the amount in extracellular fluid, most especially in the intervascular space or in the bloodstream, is extremely low. The gap between the two measurements represents anions not routinely measured, such as sulfates, phosphates, proteins, and organic acids such as lactic and ketone acids. The normal range is 80 to 14 milliequivalents per liter. An increase greater than 14 milliequivalents indicates an increase in percentage of one or more unmeasured anions in the bloodstream. Increases can occur with acidotic conditions characterized by a higher than normal amount of organic acids, such as lactic acidosis or ketoacidosis seen in diabetics. Babies and young children have less homeostatic buffering capacity than older children and adults. The pediatric patient tends towards being slightly metabolic acidotic, which may be related to higher metabolic acid production and renal immaturity. The pH of pediatric patients normally averages 7.30 to 7.35. Older adults experience physiologic changes that influence acid-base balance. In the kidneys, the decreased distal tubule response to vasopressin results in reduced ability to correct acid-base balances. Decreased chest wall compliance, decreased elasticity of lung tissue, decreased number of alveoli, and decreased strength of expiratory muscles lead to difficulty in regulating pH. So a normal finding in older adults is usually a decrease in PaCO2 level. The older adult can usually maintain acid-base balance under normal conditions, but may need more time to return to normal after an acidosis or an alkalosis event, because older adults do not possess reserves or the ability to adapt readily to rapid changes in acid-base balance. Pregnancy is associated with compensated respiratory alkalosis. It is believed to be caused by hyperventilation from the stimulating effects of the hormone progesterone on the respiratory center in the medulla. PaCO2 usually decreases to approximately 30 millimeters of mercury during pregnancy, and the arterial pH is generally 7.44. The bicarbonate level drops to approximately 20 milliequivalents per liter by the third trimester, thus resulting in a total buffering capacity reduction by renal compensation. The two major types of acid-base imbalances are alkalosis and acidosis. Each type can be respiratory or metabolic in origin and primary or compensated. Additionally, an acid-base imbalance is classified as mixed or combined when both metabolic imbalance and a respiratory imbalance occur at the same time. A thorough assessment, including careful evaluation of arterial blood gas values, is essential for determining which type of imbalance a patient has. Nursing care focuses on monitoring the patient and correcting the imbalance. Respiratory acidosis is a primary acid-base imbalance resulting from alveolar ventilation leading to carbon dioxide retention, resulting in lower arterial pH and elevated serum carbon dioxide levels. Alveolar hypoventilation is the most common cause. It is manifested by abnormally slow or shallow respirations or poor alveolar ventilation, resulting in inadequate gas exchange, causing carbon dioxide to accumulate in the lungs and serum, as well as increased levels of circulating carbonic acid and a low pH. It may be acute, as in a sudden ventilatory failure, or chronic, as in emphysema. The body attempts to compensate by increasing renal absorption of bicarbonate. Besides alveolar hypoventilation, respiratory acidosis can also be caused by acute abdominal distension, which inhibits pulmonary excursion, respiratory arrest, overdose of sedatives or anesthetics, airway obstruction, pneumonia, and chest wall injury. The listing of steps on this slide outlines how respiratory acidosis develops at the cellular level. When pulmonary ventilation decreases, retained carbon dioxide combines with water to form carbonic acid in larger than normal amounts. The carbonic acid dissociates to release free hydrogen ions and bicarbonate ions. The excessive carbonic acid causes a drop in pH. Assessment-wise, look for a partial pressure of carbon dioxide level that is above 45 millimeters of mercury and a pH level below 7.35. As the pH level falls, diphosphoglycerate increases in red blood cells and causes a change in hemoglobin that makes the hemoglobin release oxygen. The altered hemoglobin is now strongly alkaline, picking up hydrogen ions and carbon dioxide ions, thus eliminating some of the hydrogen ions and excess CO2. Assessment-wise, look for a decrease in arterial oxygen saturation. Whenever PaCO2 increases, carbon dioxide builds up in all tissues and fluids, including cerebrospinal fluid and the respiratory center in the medulla. The CO2 reacts with water to form carbonic acid, when then breaks into hydrogen ions and bicarbonate ions. The increased amount of CO2 and free hydrogen ions stimulate the respiratory center to increase the respiratory rate. An increased respiratory rate expels CO2 and helps to reduce the CO2 level in the blood and other tissues. Assessment-wise, look for rapid, shallow respirations and a decreasing PaCO2. Eventually, carbon dioxide and hydrogen ions cause cerebral blood vessels to dilate, which increases blood flow to the brain. That increased flow can cause cerebral edema and depress central nervous system activity. Assessment-wise, look for headache, confusion, lethargy, nausea, or vomiting. As the respiratory mechanism fails, the increasing PaCO2 stimulates the kidneys to conserve bicarbonate ions and sodium ions and to excrete hydrogen ions. The additional bicarbonate ions and sodium ions combine to form extra sodium bicarbonate, which can then buffer more free hydrogen ions. Assessment-wise, look for increased acid content in the urine, increasing serum pH and bicarbonate levels, and shallow depressed respirations. As a concentration of hydrogen ions overwhelms the body's compensatory mechanisms, hydrogen ions move into the cells and potassium ions move out. A concurrent lack of oxygen causes an increase in anaerobic production of lactic acid, which further skews the acid-base balance and critically depresses the neurological and cardiac function. Assessment-wise, look for hyperkalemia, dysrhythmias, increased PaCO2 levels, decreased arterial oxygen pressure level, decreased pH, and a decreased level of consciousness. Assessment findings include dyspnea, tachycardia, slow, shallow respirations, diminished or absent breath sounds over the affected area, confusion, headache, tremors, dizziness, seizures, warm flushed skin, altered level of consciousness, and cyanosis. Uncompensated ABG results reflect a pH less than 7.35, a PaCO2 greater than 45 millimeters of mercury, and a bicarbonate level of 22 to 26 milliequivalents per liter. Compensated respiratory acidosis ABG findings are a pH that is 7.35 or slightly lower, a PaCO2 greater than 45 millimeters of mercury, and a bicarbonate level greater than 26 milliequivalents per liter. When the underlying cause is pulmonary, the treatment goal is correcting or improving ventilation and lowering PaCO2 levels. When the underlying cause is non-pulmonary, such as seen in neuromuscular disorders or drug overdose, the goal of treatment is to improve the underlying cause. Multiple measures may be ordered by the healthcare provider to correct the pulmonary causes, such as bronchodilators to open up constricted airways, supplemental oxygen, drug therapy to treat hyperkalemia, antibiotic therapy to treat infection, chest physiotherapy to remove secretions from the lungs, removal of a foreign body from the airway, and the insertion of an artificial airway for mechanical ventilation if hypoventilation cannot be corrected with other less invasive measures. Nursing interventions for respiratory acidosis include encouraging the patient to turn, cough, and deep breathe deeply at least every 2 hours, which improves ventilation. Maintain a patent airway through the use of measures such as suctioning to prevent CO2 retention. Monitor ABG levels for changes in pH and CO2. Monitor vital signs, particularly the respiratory rate and depth, for changes that may indicate worsening acidosis. Assist with endotracheal intubation if the patient remains unable to ventilate adequately. Monitor neurological status and report significant changes. Position the patient in the semi-Fowler's position to ease breathing. Ensure the patient drinks 2 to 3 quarts or 2 to 3 liters of fluids daily, unless it's contraindicated, to help liquefy secretions, aid their expulsion, and promote adequate carbon dioxide exchange. Administer supplemental oxygen as ordered. Do so cautiously in a patient with COPD because excessive oxygen decreases or completely depresses the ventilatory drive and may worsen acidosis. Monitor serum potassium levels for hyperkalemia because potassium moves out of the cell during respiratory acidosis. Administer medications as ordered to treat the underlying respiratory dysfunction, for example, bronchodilator for bronchospasms, an antibiotic for respiratory infection. Administer sedatives cautiously. Many of them depress the respiratory drive, which can lead to carbon dioxide accumulation. Provide emotional support and reassurance to the patient, who likely will be quite anxious. Institute safety measures as needed to protect a confused patient. Provide patient teaching as necessary, such as preventative measures, including coughing and deep breathing techniques, the need for supplemental oxygen therapy or home oxygen therapy if indicated, proper technique for using bronchodilators, and the need for repeated ABG analysis are important teaching points as well. Respiratory alkalosis occurs when the alveolar hyperventilation results in decreased serum carbon dioxide levels, hypocapnia, causing excessive carbon dioxide exhalation. The decreased carbon dioxide levels leads to decreased carbonic acid production, in turn leads to increased arterial blood pH. It may be acute, resulting from a sudden increase in ventilation, or chronic, which may be difficult to identify because of renal compensation. The body attempts to compensate by increasing renal excretion of bicarbonate. It can take up to 24 to 48 hours. The most common cause is hyperventilation, such as seen in psychogenic conditions like hysteria or anxiety. Other causes include overventilation with a mechanical ventilator, aspirin overdose, and hypermetabolic states such as fever or sepsis, severe pain, central nervous system trauma or lesions, hepatic failure, hypoxia, pregnancy, and hyperventilation during labor and delivery. The steps on this slide outlines how respiratory alkalosis develops at the cellular level. When pulmonary ventilation increases above the amount needed to maintain normal carbon dioxide levels, excessive amounts of carbon dioxide are exhaled. This causes hypocapnia, a fall in partial pressure of arterial carbon dioxide, PaCO2, which leads to a reduction in carbonic acid production, a loss of hydrogen ions and bicarbonate ions, and a subsequent rise in pH. Assessment findings include a pH level above 7.45, a PCO2 level below 35 millimeters of mercury, and a bicarbonate level below 22 milliequivalents per liter. In defense against the rising pH, hydrogen ions are pulled out of the cells and into the blood in exchange for potassium. Hydrogen ions enter the blood combine with bicarbonate ions to form carbonic acid, which lowers the pH. Assessment-wise, look for a further decrease in bicarbonate levels, a fall in pH, and a fall in serum potassium levels, or hypokalemia. Hypocapnia stimulates the carotid and aortic bodies in the medulla, which causes an increase in heart rate without an increase in blood pressure. Look for the patient complaint of angina and ECG changes. Patient will be restless and most probably anxious. Simultaneously, hypocapnia produces cerebral vasoconstriction, which promotes a reduction in cerebral blood flow. Hypocapnia also overexcites the medulla, pons, and other parts of the autonomic nervous system. Look for increased anxiety, diaphoresis, dyspnea, alternating periods of apnea and hyperventilation, dizziness, and tingling in fingers and toes. When hypocapnia lasts more than 6 hours, the kidneys increase secretion of bicarbonate ions and reduce excretion of hydrogen ions. Periods of apnea may result if pH remains high and the PaCO2 remains low. Assessment-wise, look for slowing of the respiratory rate, hypoventilation, Cheyne-Stokes respirations. Continued low PaCO2 increases cerebral and peripheral hypoxia from vasoconstriction. Severe alkalosis inhibits calcium ionization, which in turn causes increased nerve excitability and muscle contractions. Eventually, The alkalosis overwhelms the central nervous system and the heart. Assessment-wise, look for decreasing level of consciousness, hyperreflexia, carpal pedal spasm, tetania, dysrhythmias, seizure, and coma. Assessment findings include rapid deep respirations, tachycardia, lightheadedness, vertigo, decreased concentration and attention span, paresthesia, tetany, carpal pedal spasm, ringing in the ears, palpitations, dry mouth, blurred vision, syncope, seizures and coma, hyperactive deep tendon reflexes, twitching, and dysrhythmias. Lab findings for uncompensated respiratory alkalosis include a pH greater than 7.45, a PaCO2 level less than 35 millimeters of mercury, a partial pressure of arterial oxygen is usually normal or elevated, and a bicarbonate level of 22 to 26 milliequivalents per liter. Lab findings for compensated respiratory alkalosis include an arterial pH that is usually borderline or slightly higher, a PaCO2 level less than 35 millimeters of mercury, a bicarbonate level less than 22 milliequivalents per liter, serum potassium level less than 3.8 milliequivalents per liter, urine pH which is alkaline, and a serum calcium level usually less than 7 milligrams per deciliter. Excuse me. Several measures taken to correct the respiratory alkalosis include orders from the healthcare provider to probably discontinue the causative agent, such as salicylates or aspirin products or other drugs that contain salicylates, steps to reduce fever, eliminate source of sepsis, oxygen therapy to treat acute hypoxemia, and sedative or analytics to treat the anxiety. The healthcare provider may include orders to counteract hyperventilation, including teaching the patient to breathe into a paper bag or cupped hands. This forces the patient to breathe exhaled CO2 and raise CO2 levels in the blood. For intubated patients, orders for adjusting mechanical ventilator settings as needed by decreasing tidal volume or number of breaths per minute. The nursing interventions for a patient in respiratory alkalosis include monitoring vital signs, specifically respiratory rate and rhythm, instructing the patient to breathe slowly and less deeply to decrease carbon dioxide loss. Have the patient breathe into a paper bag or use a rebreather mask to rebreathe CO2. If the patient is intubated, adjust the mechanical ventilator settings to decrease ventilatory rate and depth. Administer sedatives as ordered to slow the respiratory rate. Monitor the patient carefully to guard against respiratory depression and carbon dioxide retention. Intervene as necessary to correct the underlying cause of hyperventilation, such as pain or anxiety. Monitor ABG values, particularly the PaCO2 levels, to evaluate the effectiveness of your interventions. Monitor laboratory results for values indicating compensation, such as a decrease bicarbonate levels and normalization of the pH level. Remember, it takes the renal system several hours to respond, so do not expect the bicarbonate pH to normalize until at least 24 hours after the onset of hypoventilation. Monitor for low serum potassium levels in a patient with chronic hyperventilation because potassium is exchanged for hydrogen ions and moves from the ECF to the ICF. Provide undisturbed rest periods after the patient's respiratory rate returns to normal because hyperventilation may result in severe fatigue. Stay with the patient during periods of extreme stress and anxiety. Offer reassurance and maintain a calm, quiet environment. Provide teaching as appropriate, as anxiety reducing techniques and controlling breathing exercises. Metabolic acidosis results from the loss of bicarbonate from extracellular fluid, accumulation of metabolic acids, or a combination of the two. Metabolic acidosis, such as hydrochloric acid, are produced by metabolism or ingested foods. Chloride, component of hydrochloric acid, competes with the bicarbonate for combination with sodium. Increased metabolic acid production is caused by excessive chloride retention or ingestion. The kidneys cannot retain sufficient bicarbonate to compensate, resulting in an excess of hydrogen ions, and eventually metabolic acidosis develops. The major signs are a decreased arterial pH accompanied by a decreased bicarbonate level. Metabolic acidosis never results from respiratory problems, with the exception of lactic acidosis from anaerobic metabolism. The body attempts to compensate for metabolic acidosis through hyperventilation. Causes of metabolic acidosis include diabetic ketoacidosis, excessive acid accumulation as seen in renal failure or salicylate toxicity, diuretic therapy resulting in excess bicarbonate loss through the kidneys, excess loss of bicarbonate from the intestines such as from prolonged severe diarrhea, chronic alcoholism, starvation, hypoxia, and anaerobic carbohydrate metabolism. Lactate, produced as a result of carbohydrate metabolism, is metabolized by the liver. The normal lactate level is 0.93 to 1.65 milliequivalents per liter with tissue hypoxia. However, cells are forced to switch to anaerobic metabolism and more lactate is produced. When lactate accumulates in the body faster than it can be metabolized, lactic acidosis occurs. It can happen any time the demand for oxygen in the body is greater than its availability. Causes of lactic acidosis include septic shock, cardiac arrest, pulmonary disease, seizures, and strenuous exercises. The latter two cause transient lactic acidosis. Hepatic disorders can also cause lactic acidosis because the liver cannot metabolize lactate. The treatment focuses on eliminating the underlying cause. If the pH is below 7.1, sodium bicarbonate may be given. Use caution when administering sodium bicarbonate, however, because it may cause alkalosis. This slide outlines the steps of how metabolic acidosis develops at the cellular levels. As hydrogen ions start to accumulate in the body, chemical buffers in the cells and extracellular fluid bind with them. No assessments, criteria, or manifestations are detectable at this point of the process. Excessive hydrogen ions that do not bind with the buffers decrease pH to increase the respiratory rate. The increased respiratory rate lowers partial pressure of arterial carbon dioxide, which allows more hydrogen ions to bind with bicarbonate ions. Respiratory compensation occurs within minutes, but it is not sufficient to correct the imbalance. Assessment-wise, look for a pH level below 7.35, a bicarbonate level below 22 milliequivalents per liter, and a decreasing PaCO2 level, and rapid, deeper respirations. Healthy kidneys try to compensate for acidosis by excreting excess hydrogen ions into the renal tubules. Those ions are buffered by phosphate or ammonia and then are excreted into the urine in the form of a weak acid. Assessment-wise, look for acid in the urine. Each time a hydrogen ion is secreted into the renal tubules, a sodium ion and a bicarbonate ion are absorbed from the tubules and returned to the blood. Assessment-wise, look for a pH and bicarbonate levels that return slowly to normal. Excessive hydrogen ions in the extracellular fluid diffuse into the cells. To maintain the balance of change across the membrane, the cells release potassium ions into the blood. Look for manifestations of hyperkalemia, including colic and diarrhea, weakness or flaccid paralysis, tingling and numbness in the extremities, bradycardia, a tall T wave, a prolonged PR interval, and a wide QRS complex. Excessive hydrogen ions alter the normal balance of potassium ions, sodium ions, and calcium ions, leading to reduced excitability of nerve cells. Look for manifestations of progressive central nervous system depression, including lethargy, dull headache, confusion, stupor, and coma. Assessment findings include Kussmaul's respiration, lethargy, drowsiness, confusion, headache, flushed warm dry skin, fruity smelling breath, peripheral vasodilation, nausea and vomiting, twitching, hypotension, dysrhythmias, seizures, stupor, and coma. Laboratory findings for uncompensated metabolic acidosis include an arterial pH less than 7.35, a PaCO2 level 35 to 45 millimeters of mercury, arterial bicarbonate level less than 22 milliequivalents per liter, negative base excess, and a serum carbon dioxide level less than 18 milliequivalents per liter. Laboratory findings for compensated metabolic acidosis include an arterial pH borderline 7.35 or slightly lower, carbon dioxide level less than 35 millimeters of mercury, arterial bicarbonate level less than 22 milliequivalents per liter, base excess negative, a serum potassium level greater than 5.5 milliequivalents per liter, and a urine pH less than or equal to 4.5. Treatment orders by the healthcare provider might include mechanical ventilation if needed to assist respiratory compensation, sodium bicarbonate IV to neutralize blood acidity in patients with pH lower than 7.1, and bicarbonate loss. Parenteral fluid replacement as needed to maintain fluid balance, dialysis for patients with renal failure or toxic reaction to drug, rapid-acting insulin for patients with diabetes to reverse diabetes ketoacidosis and drive potassium back into the cells, and antidiarrheals to treat diarrhea induced bicarbonate loss. Nursing interventions for a patient with metabolic acidosis include monitoring patients at risk for metabolic acidosis, especially those with diabetes mellitus, sepsis, or shock. Monitor vital signs, particularly rate and depth of respirations. Monitor neurological status closely because changes occur rapidly. Monitor ABG values, particularly the pH, because small decreases in pH indicate large increases in hydrogen ion concentration. Monitor bicarbonate and potassium levels. Low bicarbonate and high potassium levels may be early signs of acidosis. Institute cardiac monitoring for a patient with elevated serum potassium levels. Insert an IV line as ordered and maintain patent IV access. Have a large bore catheter in place for emergency situations. Administer sodium bicarbonate cautiously through an existing IV line in a large vein. Flush line with normal saline solution before and after administering sodium bicarbonate. It is incompatible with many drugs and may have activated or caused precipitation if administered with incompatible drugs. Be aware that too much bicarbonate can cause metabolic alkalosis and pulmonary edema. Position the patient to promote chest expansion and facilitate breathing if the patient is stuporous. Turn the patient frequently. Intervene to correct the underlying cause of acidosis as necessary. In many cases, correction of the underlying problem will resolve acidosis. Averting need for more aggressive interventions such as sodium bicarbonate administration. Administer IV fluids containing lactate as ordered, unless contraindicated. Lactate is converted into bicarbonate in the liver. Administer insulin and normal saline solutions to correct hyperglycemia in a diabetic patient with metabolic acidosis linked to hyperglycemia. Remember, the insulin administration will also lower serum potassium levels. Administer oxygen to correct lactic acidosis linked to overexertion by decreasing hypoxemia and triggering conversion to aerobic metabolism. Expect to assist with peritoneal or hemodialysis to correct pH in renal failure, drug overdose, or poisonings. Provide a high carbohydrate, low fat diet for a patient with chronic acidosis. This will decrease metabolic waste products and therefore improve acidosis. Orient the patient as needed. If confused, take steps to ensure safety, such as keeping the patient's bed in low position. Investigate reasons as appropriate for patient's ingestion of toxic substances. Provide the patient teaching as necessary for the need for blood glucose testing and strict adherence to anti-diabetic therapy as indicated and as is appropriate. Metabolic alkalosis results from loss of hydrogen ions, gain in bicarbonate, or both. Loss of a metabolic acid results in an increased pH level. pH increases as hydrogen ion concentration decreases. As the hydrogen ion concentration decreases, more carbonic acid dissociation occurs and the bicarbonate concentration is increased through renal reabsorption. This process results in increased renal excretion of hydrogen, chloride, and potassium. Chloride competes with bicarbonate for combination with sodium. As the chloride level falls, the bicarbonate level rises. The body attempts to compensate for metabolic alkalosis through hypoventilation. With the stimulation of chemoreceptors, respiration rate decreases to conserve carbon dioxide. The causes of metabolic acidosis include the excessive administration or ingestion of bicarbonate, such as with many forms of antacids. Other causes are the excessive loss of hydrogen from nasogastric suctioning or vomiting, prolonged diuretic therapy, particularly potassium wasting diuretics such as Lasix, sodium bicarbonate administration during cardiopulmonary resuscitation, hypokalemia, hyperaldosteronism, and renal stenosis. This slide outlines how metabolic alkalosis develops at the cellular level. As bicarbonate ions start to accumulate in the body, chemical buffers in the extracellular fluid and cells bind with the ions. No signs are detectable on assessment at this stage. Excessive bicarbonate ions that do not bind with chemical buffers elevate serum pH levels, which in turn depress chemoreceptors in the medulla. Depression of these chemoreceptors causes a decrease in the respiratory rate, which increases the partial pressure of carbon dioxide. The initial carbon dioxide combines with water to form carbonic acid. Lower oxygen levels limit respiratory compensation. Look for a serum pH level above 7.45, a bicarbonate level above 26 milliequivalents per liter, a rising PaCO2, and slow, shallow respirations on assessment. When the bicarbonate level exceeds 28 milliequivalents per liter, the renal glomeruli can no longer reabsorb excessive bicarbonate ions. The excessive bicarbonate is excreted in the urine. Hydrogen ions are retained. Look for alkaline urine and pH and bicarbonate levels that return slowly to normal in your assessment. To maintain electrochemical balance, the kidneys excrete excessive sodium ions, water, and bicarbonate ions. Look for polyuria. Initially, then manifestations of hypovolemia, including thirst and dry mucous membranes. Lowered hydrogen ion levels in the extracellular fluid cause the ions to diffuse out of the cells. To maintain balance of charge across the cell membranes, extracellular potassium ions move into the cells. Look for manifestations of hypokalemia, including anorexia, muscle weakness, and loss of reflexes, and other signs of low potassium. As levels of hydrogen ions decline, calcium ionization decreases. The decrease in ionization makes cells more permeable to sodium ions. Sodium ions moving into nerve cells stimulate neural impulses and produce overexcitability of the peripheral and central nervous systems. Assessment-wise, look for tetany, belligerence, irritability, disorientation, and seizure manifestations. Assessment findings of metabolic alkalosis include decreased respiratory rate and depth, hypotension, dizziness, paresthesia in fingers and toes, circummoral paresthesia, carpal pedal spasm, muscle hypertonicity, nausea and vomiting, confusion, irritability, agitation, seizures, and coma. Laboratory findings for uncompensated metabolic alkalosis include arterial pH greater than 7.45, arterial carbon dioxide level of 35 to 45 millimeters per mercury, arterial bicarbonate level greater than 26 milliequivalents per liter, a positive base excess, and an arterial carbon dioxide level greater than 28 milliequivalents per liter. Laboratory findings for compensated metabolic alkalosis include arterial pH borderline at about 7.45 or possibly higher, carbon dioxide level greater than 45 millimeters of mercury, arterial bicarbonate level greater than 26 milliequivalents per liter, a positive base excess, and serum potassium and chloride levels decreased. The treatment orders by the healthcare provider may include discontinuation of diuretic therapy and nasogastric suctioning, the administration of an antiemetic to treat underlying nausea and vomiting, the administration of Diamox, which is a diuretic, to decrease renal excretion of bicarbonate. Nursing interventions include the monitoring of patients at risk for metabolic alkalosis, particularly those with gastric fluid loss from long-term NG suctioning or vomiting. Assess fluid intake and output to determine the amount of gastric fluid loss. Monitor vital signs, especially respirations, which will usually decrease as the body attempts to conserve carbon dioxide. Monitor heart rate and rhythm to detect hypokalemia. A 12-lead ECG may be indicated. Assess the patient's level of consciousness. Watch for apathy and confusion, which may be evident in patient's conversation. Watch closely for manifestations of muscle weakness, tetany, or decreased activity. Intervene as necessary to correct the underlying cause of the imbalance. For example, control vomiting by administering antiemetics. Monitor ABG values. Administer IV fluid and electrolyte supplements as ordered to replace fluid volume, potassium, and chloride losses. Monitor electrolyte studies to prevent over-replacement. Administer diluted potassium solutions with an infusion device and IV pump. Supply sufficient chloride to enable renal absorption of sodium with chloride and subsequent renal excretion of excessive bicarb. Irrigate an NG tube connected to suction with normal saline solution instead of tap water to prevent loss of gastric electrolytes. When providing teaching to a patient with metabolic alkalosis, be sure to cover the following points and evaluate the patient's learning. Teach the patient and family about metabolic alkalosis, including causes and associated risk. Warn the patient and family about the dangers of excessive bicarbonate ingestion. Explain that alkalosis can develop from overuse of antacids or sodium bicarb. Teach the patient taking a potassium-wasting diuretic to watch for and report manifestations of hypokalemia, such as weakness and excessive urine output to their healthcare provider. Teach the patient how to replace potassium by increasing dietary intake or taking oral supplements.